Hello, everybody. My name is Dr. Rajal Shah. I welcome you to my YouTube channel. Thank you for joining. So in your practice, you might have observed that there has been a paradigm shift in the way now prostate cancer is diagnosed and managed. And this paradigm shift is nothing other than application of multiparametric MRI technique. Now, MRI is the imaging of choice in patients suspected of having a clinically significant prostate cancer. So as a pathologist, it is very important for us to understand and apply and integrate this technique in your routine day-to-day reporting and diagnosis. So in today's video, I'm going to focus on this particular issue. So first, we really need to understand why this paradigm shift occurred, what caused that particular shift. So let's understand that PSA screening was introduced in 1980s. And with that introduction of PSA screening, we saw that there is a trend toward lower stage prostate cancer detection. Diagnosis of prostate cancer these days is mainly triggered by an elevated or a rising PSA. Sexton biopsies were introduced in 1989, which targeted specifically the paramedian side of 3 cores from each prostate sites. But now then it was realized later on that when you move the prostate biopsies more towards the laterally and towards the anterior horn of the prostate tissue, then you are going to improve the prostate cancer detection. And this particular finding led to kind of proposal for variety of different extended and some saturation biopsy protocols. Extended biopsy is typically defined as 8 or more cores. Typically, you are going to get 12 cores, and in that 6 cores are from the sextant areas, and then 6 cores are from the more peripheral aspect of the prostate. And then extended biopsy is now very infrequently utilized extensive sampling technique that should be reserved only in select situation, but as much as 24 or more cores can be taken in this particular biopsy technique. And this cartoon, which I have taken from our book, shows you the comparison of these locations and overall sampling approach for these 3 biopsy techniques: sextant biopsy, extended biopsy, and saturation biopsy. So with these more laterally directed protocols, we clearly started seeing increased cancer detection, as shown here in this box and whisker plot, that by increasing the by increasing the biopsy samples in your technique, you are going to proportionately see increase of cancer detection. But this cancer detection is also at the same time has a finding of more clinically insignificant cancers. As shown here in this particular graph, in this study, the number of biopsy cores taken were a major independent predictor of having clinically insignificant prostate cancer at radical prostatectomy. So the major controversy and criticism for PSA screening is that we are potentially overdiagnosing and therefore over-treating prostate cancers. And this particular criticism led to need for reducing the overdiagnosis of clinically insignificant prostate cancer, and also need to reduce unnecessary prostate biopsies, as prostate biopsies has significant complications with higher morbidity that can cause sometimes significant complications to the patient. So due to this need, MRI has clearly evolved because of its high soft tissue contrast, high spatial resolution, and same time additional functional imaging capabilities. It provides a much superior resolution to identify the targets for prostate biopsies. It can define the staging characteristics of the prostate cancer in comparison to standard ultrasound guided biopsy techniques. So this cartoon shows you that when you use standard sampling techniques without the use of multiparametric MRI, you can miss the clinically significant prostate cancer. These black dots indicates the number of biopsy course taken as well as the location for that. So in this particular biopsy, you can see this clinically significant cancer, which is situated here, not in the path of the biopsy course, is totally remains unsampled. While with multiparametric MRI, you target or you specifically identify these areas of regions of interest and then target those regions of interest in addition to standard sampling, and that's how you can improve the detection of clinically significant prostate cancer. So there has been 3 clinical trials which have validated the utility of multiparametric MRI. I'm going to provide you very succinct details for these 3 trials. The first clinical trial is called PROMISE. It is a UK-based study which is kind of aimed as diagnostic accuracy of multiparametric MRI and transrectal ultrasound biopsy in prostate cancer, a paired validating confirmatory study. So in this study, basically they compared the diagnostic accuracy of multiparametric MRI in comparison to truss biopsy using transperineal template mapping biopsies as a standard technique. And the conduct and reporting of each test was blinded to others. So what did they find? PROMISE study showed that mpMRI has significantly better sensitivity and negative predictive value for clinically important prostate cancer compared to transrectal ultrasound biopsy. So mpMRI could be used as a triage test before the first biopsy to allow 1/4 of men at risk to avoid biopsy. That's a significant reduction of necessity for the biopsies for patients. Second important clinical trial is called Precision trial that was published in New England Journal of Medicine. It aims to determine multiparametric MRI with or without targeted biopsy can be an alternative to standard transrectal ultrasound guided biopsy for prostate cancer detection in men with a raised PSA who is biopsy naive. And what did they find? The most important observation that you could spare as many as 28% of biopsies if you use MRI and targeted biopsies. So the conclusion was that the use of risk assessment with MRI before biopsy and MRI targeted biopsy was superior to standard transrectal ultrasound guided biopsy in men at clinical risk for prostate cancer who had not undergone biopsy. So again, somewhat similar observations. And then the third trial is called MRI First trial, which was published in 2019. It aimed to determine whether multiparametric MRI improved the detection of clinically significant prostate cancer, and essentially one can avoid the need for a systemic biopsy or not. So what did they find? So they find that there was no difference between systemic and targeted biopsy in detection of grade group 2 or high prostate cancer. However, detection is improved when you combine both techniques with substantial added value. So multiparametric MRI before biopsy in biopsy naive patients can improve the detection of clinically significant prostate cancer, but does not seem to avoid the need for systemic biopsies. So these days, majority of prostate biopsies, you are going to see 2 components, targeted biopsy, and in addition, a systemic extended biopsies, the way that we used to receive before the introduction of multiparametric MRI. So if we summarize these 3 clinical trials, what is the observation that pre-biopsy MRI reduces the over-detection of 37% of clinically insignificant cancer, reducing unnecessary biopsies by 32%, although at cost of missing 4% of clinically significant cancer. Its sensitivity has been reported to be 74% to 82%, specificity 65% to 94%. So there has been a broad range that has been reported. And its negative predictive value is, of course, similar as the specificity. So it has a high negative predictive value. Means if you have a negative MRI, you could potentially spare the patient from doing a unnecessary biopsy, but at a risk of small risk of missing a clinically significant prostate cancer. So this table shows you various clinical indications for multiparametric MRI. The most important one that I discuss with you is when you are suspecting a clinically significant prostate cancer in a patient. Once prostate cancer is diagnosed, another important component of reporting is the staging parameters, particularly every MRI report. They would indicate some degree of suspicion for extraprostatic extension and seminal vesicle invasion. You might have also some comment on lymph nodes status. And these two parameters now has been applied in patients that are put on active surveillance and then further monitoring of these patients. So this is a major application of multiparametric MRI these days, number 1 and number 3. And I will talk more about that, how this active surveillance monitoring has been utilized with this technique. There has been also increasing use of high frequency ablation therapy. So we need to identify correctly the significant lesions. And that's where also mpMRI is increasingly being utilized. And rarely it can also be utilized for pelvis evaluation of pelvis after biochemical recurrence. So mpMRI has 4 sequences or 4 protocols. Number 1 is a T2 weighted images, which looks at the water content. So it provides you superior anatomical clarity and details as shown here. So this is one of the most common sequence that is reported. The second important component is diffusion weighted imaging, which looks at the cell density as shown here. So prostate cancer appears a lot more dense in diffusion weighted imaging. It has another parameter that they report based on the high B value called apparent diffusion coefficient, and I will talk a little bit about that in next couple of slides. Third functional parameter is dynamic contrast enhanced imaging, which looks at the vascular area of the tissue. So this is a very dynamic functional imaging, which is somewhat infrequently utilized, but the most commonly utilized sequences are these 3. T1 weighted imaging is utilized to particularly provide the staging information related to the patients. So multiparametric MRI reporting follows standardized sector map for anatomical localization. So based on the zonal anatomy of the prostate, about 36 sectors are defined, 2 for seminal vesicles and 1 for the urethral sphincter. So we are totally they have 38 sectors, and based on that zonal location, they define the Pirate scores and the anatomical location of the suspected clinical cancer. And using this particularly sequences, they defined a lesion into Pirates 1 to 5 category. With increasing Pirates 1, you are likely to have more clinically significant cancer. Pirates 3 to 5 is typically clinically visible or a visible cancer. And Pirates 4 and 5 is considered highly suspicious for clinically significant cancer. So Pirates 3 is defined as a clinically significant cancer equivocal. Pirates 4 clinically significant cancer is likely, and Pirates 5 is clinically significant cancer is very likely. And if we look at that PROMISE study, which I mentioned to you, you can see that with the increasing Pirate scores, you are having a detection of more clinically significant cancer. and a reduction on the number of clinically insignificant cancers. PIRATES 1 and 2 has still a lot of clinically insignificant cancers. PIRATES 3 still can detect a lot of clinically insignificant cancers, but particularly PIRATES 4 and 5 are the one that when present, particularly prostate biopsies is very, very important to perform. Typically, they would perform the biopsy in anywhere PIRATES score 3 to 5 with that increased probability, as I mentioned to you. So apparent diffusion coefficient, different coefficient is another parameter which quantifies the restriction of water diffusion and is inversely related to Gleason grade. So you can see that higher Gleason grade has a more dense ADC or more lower, more dense look in the functional imaging characteristics, but lower ADC value. And this study shows that both ADC value and Gleason grade are inversely correlated. So with increasing Gleason grade, you are going to have lower ADC value. So you can argue that they are also kind of to some extent venturing on the providing grading of the prostate cancer. You might see in the reporting that there is a low ADC value, which increases the likelihood of grade group 2 or higher prostate cancer. That would be the typical language that we encounter in our reporting at our center by our radiologist. Another parameter that is reported frequently is extraprostatic extension and seminal vesicle invasion, the probability for both of that. MRI has high specificity for diagnosing extraprostatic extension, seminal vesicle invasion, and lymph node metastasis, but its sensitivity remains lower. So when you see abnormal finding, particularly highly concerning for seminal vesicle invasion or extraprostatic extension, try to make sure that you also look very carefully to make sure that you don't miss this particular correlation. So this multiparametric MRI-guided biopsies are mainly two types. One is so-called direct MRI-guided biopsies, in which MRI biopsies are taken completely under MRI guidance. And the second one, which is called MRI fusion biopsies, in which after the patient undergoes MRI, there is a fusion of the or overlay of the ultrasound images and the MRI images are done. The targets are defined, and patients will have targeted biopsies and also in addition systemic biopsies, while in MRI-guided biopsies, typically systemic biopsies are avoided. So this table shows you the correlation between MRI ultrasound fusion biopsy and MRI-guided in-bore biopsy. MRI-guided biopsy, in-bore biopsies are quite expensive. It takes longer time. It is a lot more complex. Operator is typically radiologist compared to urologist for MRI ultrasound fusion guided biopsies. So it is highly operator dependent, particularly MRI guided in biopsies, but it has ability to target small lesions, typically less than 1 centimeter. And both of these can have as a lesional documentation. So that part is available in both of the particular techniques. So in general, in my experience, MRI-guided in-bore biopsies are still infrequently utilized. Most commonly, what you see is MRI ultrasound fusion biopsies, in which after taking lesional tissue, standards course are also taken. This table shows you that prostate MRI also has several challenges. It shows you some of the difficulties that one can encounter there, which can be divided on the MRI quality, prostate factors, radiologist dependence factors, and patient dependent factors. Few things that we really need to understand is that the correlation may be not good when small size of the gland is an issue. Certain benign conditions mimicking cancer, particularly adenosis, granulomatous prostatitis, acute inflammation, can also give you false positive readings. we have also seen, which I'm going to talk about our study, but MRI visibility is highly dependent on the tumor size and presence of pattern 4, as well as location of the tumor within the prostate. There are also many important radiological factors that you should be aware about. I think similar like pathologists, this is also radiologist dependent. Those who are experienced in doing this are going to have more better inter-observer reproducibility, but there is a significant subjective interpretation issue that exists even with this technique as well. Reporting style variation is also an issue. Certain patient factors that you should be aware about is that particularly when patient has any metal artifacts or metal devices in their body, typically MRI is not performed, MRI is not reliable. Biopsy-related hemorrhage can also produce artifacts, and that can cause difficulty in reading. Previous treatment is also another factor. So there has been some controversies that it is now kind of reasonably accepted that MRI improves the detection of clinically significant cancer, but the question still remains whether MRI can identify those aggressive pathologies like cribriform pattern 4, intraductal carcinoma. So there has been recently several studies which have looked at this particular angle. There has been some controversy in the studies. Some studies suggested that MRI is not able to accurately identify these aggressive pathologies. So we did a recent studies in which we correlated multiparametric MRI and targeted biopsy findings with subsequent patients who underwent a whole mount histopathology. So we did a correlation of MRI with this whole mount prostate pathology, and very accurately with every level we tried to correlate them, and we find some interesting observations. We saw that MRI visibility is pretty good for overall lesion level, but cribriform morphologies were still missed by the targeted biopsies in a significant number of patients. Overall MRI visibility was dependent on the size of the tumor. So typically 1 centimeter or larger tumor are more visible. The presence of Gleason pattern 4 is another important variable. So anytime you have pattern 4, you have a higher chance of visibility by MRI. So therefore 3+3 are frequently missed, but argument is that they can be clinically insignificant cancer. And then peripheral zone located tumors tend to be more visible, while anterior or transition zone located tumors can be missed by this particular imaging technique as well. So what is our role in interpretation of this guided or imaging technology-based specimen evaluation? So very important, we need to correlate MRI findings with biopsy and radical prostatectomy findings, but same time do not get biased. This is very, very important. You don't want to get biased, because particularly otherwise you may start kind of upgrading some of those patients who are monitoring and comes with a clinic imaging suspicion of having a higher Gleason grade in a repeat MRI. So that's why we really important not to need to get biased, but same time we objectively need to correlate our findings with the MRI findings. If you have discrepant cases, seek additional opinion of your colleagues. You still need to report individual Gleason grade findings for systematic biopsy per vial. Aggregated results for systemic biopsy, global or per side, is optional. But studies have also shown that when you look at the multiple cohorts within the same lesion, providing aggregated results can provide you a better correlation, particularly with the Gleason grade of biopsy and final radical prostatectomy, because the lesional biopsy cohorts are targeted to a very specific area of the tumor. So you are likely going to see a very kind of significant areas of the prostate cancer. So in that situation, providing a global or aggregated result can improve the correlation with the final pathology. And then you should provide possible histology explanation in case targeted core is negative, because that can provide kind of information to radiologists for potential false positive targets. So in summary, the imaging modality, multiparametric MRI is the imaging modality of choice in patients suspected of clinically significant prostate cancer. It's clearly a game changer now. But both pathologists and radiologists, with this adoption, I will have to collaborate more closely. But same time, beware that significant inter-observer limitations also exist amongst radiologists, and you can have false positive MRI. Pathologists need to correlate biopsy and radical prostatectomy findings with MRI, but not get biased. And I would recommend these two additional studies by these two GU societies, ISUP and GUPS, for additional reading. These two papers nicely address some of these multiparametric MRI-guided biopsy particular issues. So with that note, I hope you enjoyed this talk. If you like the talk, please don't forget to share with your with your colleagues, and please spread the word, like the channel, like the presentation, and also don't forget to subscribe. Thank you very much for your attention.